So now we're going to talk about cleft lip and cleft palate. Cleft lip and cleft palate is the most common congenital deformity that I see in my practice. It happens roughly 1 in 1,000 births throughout the United States and the world. There's variations in that statistic depending upon race and ethnicity, but overall it's about 1 in 1,000 births have a cleft lip and cleft palate. Cleft lip comes in a variety of different types. What you can see here is what you see most of the time and what you see on the web and when you're looking at those things. This is a child with a complete unilateral cleft lip and palate. The other types are microformed cleft lips and palates, which I can show you, where the lip is not totally clefted. So over here you can see it doesn't go all the way into the nose and the palate's not clefted. And this can also happen in a bilateral variety, where it happens on both sides. If we go back to this child, what you'd see here, and it's important to understand what's happening with regards to a cleft lip. In a cleft lip, there's a muscle that goes around the mouth called the orbicularis oris. And it's a big circular muscle, and it's the muscle that helps us purse our lips, talk, and act normally and smile. In the case of the cleft lip, what happened is that the muscle did not come all the way across the midline and fuse. And what you see here is that the muscle now is more of a horseshoe. And instead of inserting across the midline, it's inserting at the base of the nostril here, and the base of the nose here. And what's happening as a result of that is that the nose is being pulled out. So a cleft lip is not just a cleft lip, it's a cleft lip nasal deformity. And what you can see is that the nose is very wide. It's posterior and inferior relative to the other normal side. Surgical correction of a cleft lip has to address all of the abnormal features that are here and restore normalcy with regards to the lip. With regards to the timing of cleft lip, typically we do that around 3 months of age. And at 3 months of age, the surgery is called the malar advancement rotation. And the idea is to not only close the lip and move the nose in, but also reestablish normal anatomic structures that are in the face so that we can hide these scars, so that as these children grow, it's difficult to even tell they had the surgery because you've hidden it. And what I mean by that specifically is this structure right here is called the Cupid's bow. And if you look on me, although it's hard to tell because I have a little bit of a mustache and beard, is that there's something called the left and right philtral column, and this is called the philtrum right here. And what you see here is this is the philtral column on the normal side, and on the abnormal side, the philtral column is shortened to about half. So the surgery is to reestablish the vertical height of the lip on both sides. So as I rotate the lip down and advance the lip in, the malar advanced rotation flap, I'm going to hide the scar over here. And I'll show you some before and after pictures to kind of show you what it would look like so that you can see and understand it's not just closing the muscle together. There's a lot of things that are happening in order to do a reasonable cleft lip surgery. It's probably one of the hardest surgeries that I do because there's so many moving parts. In this child, what you can also see is that they have a cleft palate. But we're looking inside the mouth of the child. And the palate is a structure that separates the nose from the mouth. And what you're seeing here is here's the normal palate on the two sides, and this fleshy structure in the middle is actually, you're looking inside the nose. So this would normally be covered with bone and mucosa, and in children with cleft palate, what you're seeing here is a representation from the front. So if you remember that first picture where you saw that fleshy structure in the middle, you're basically looking right up into the child's nose. The palate's important for several reasons. The first of which is obviously if the baby's feeding and there's no barrier between the mouth and the nose, all the fluid just comes out of the nose. And that's important, obviously. But the other thing to understand is that we cannot speak normally if we do not have a closed palate. Because we'll then speak through our noses, and a person with an unrepaired cleft palate, it's actually almost impossible to understand their speech. So the main goal of a cleft palate surgery is to close it and reestablish normal function with regards to the palate. And we do that around age 1. The palate's made, as I said, of mucosa, which is that fleshy structure, bone in the front, and in the back it's made up of 2 muscles. And those muscles move the palate back so that as we're speaking, the nose is excluded from the mouth so that we can talk intelligently. And the other thing it does is it pulls on the structure in the ears so that our middle ear can clear the fluid that's in there. So if the middle ear, the eustachian tube, is not functioning normally because the palatal musculature is abnormal, these children typically have hearing deficits. It would sound as if you put your fingers in your ear, and that's kind of how they're hearing. So as part of the palate surgery, or palate evaluation, they have to be evaluated by a pediatric ear, nose, and throat doctor to evaluate the hearing to see if there needs to be something done with regards to the ears. There's different types of techniques to close the palate, but in short, it's to close the mucosa, bring the muscles back where they belong so that they function normally, and at the same time, the otolaryngologist, the ENT, can then perform the ear surgery to normalize the hearing. And that's about it. That surgery happens at about 1 year of age. And then after that, there's not much that's done with regards to the palate. Typically at around 2 years of age, we put these kids in early intervention with regards to speech therapy to strengthen their muscles and teach them to speak better. And then at age 5, we do a formal speech evaluation, because at age 5 is when we start to develop our adult speech patterns. Most of the time, the children are fine, and that's 95% of the time. 5% of the time, if the palatal musculature is not where it's supposed to be, or if the scar that formed inhibits the palate from moving normally, we have to perform surgery for the speech in order to help normalize the speech patterns. There's obviously a number of other things that happen in the face as the face is growing, but that, I think, in short, talks about lip and palate surgery.